Today we will discuss chronic pain and depression. Chronic pain and depression have a very real correlation. What is a little more murky is which comes first. It really becomes a chicken or an egg kind of argument because truthfully, no one is entirely sure which precedes the other. The evidence is generally across the board. However, it does appear that the majority of studies lean towards pain causing the depression. This becomes clear when you consider the vast majority of depressive episodes occur after the onset of a chronic pain condition. However, it is important to note that it is believed that patients with a history of depression typically can develop chronic pain more easily. When one looks at the research regarding patients with chronic pain with no history of depression and those that have a history but who also have chronic pain, those with the depression history generally have worse pain. What this tells us is that most likely people with a history of depression have a harder time coping with the pain that comes along with a chronic pain condition. In other words, even though they didn't have pain before, when pain does creep up and turns into a chronic condition, they do not have the requisite mental faculties and the mental ability to be able to cope with it in a healthy and desirable way. Hence, they also have a higher level of substance abuse in these patients. The important thing to focus on is the link between chronic pain and depression. Because of this link, it is important for the chronic pain provider to be vigilant in screening for depression. In addition to the depression, other complaints that usually accompany depression are anxiety, sleep disturbance, cognitive impairment, and fatigue. Given that there is such a high probability of developing depression in a chronic pain condition, why is that so? Let us discuss and look at the genetic markers that make this condition likely in a chronic pain patient. There are several genes that have been identified as risk genes for chronic pain and depression. The most commonly identified is 5-HTT-LPR, which is involved in the synthesis of serotonin and serotonin transporters. The short term of this gene has a diverse set of conditions that it can influence in a patient. Serotonin 5-HT2A and 5-HT1A receptors, catechol O-methyltransferase, dopamine D4 receptors, pro-inflammatory cytokines, interleukin A and interleukin 6. Additionally, monoamines and inflammatory cytokines play a role in GABA and glutamate neurons. All of these receptors and substances participate in the regulation of mood, which leads us to why depression and other psychological disorders could occur in a chronic pain patient. As these patients are disrupted by pain, they can start a vicious cycle and predispose the patient to the before-mentioned psychological disorders. Given that depression is such a strong indicator for chronic pain and vice versa, what does screening for depression look like in the chronic pain patient? And how is it accomplished? Let's take a look at a screening tool. If you will look to the right of the screen and available directly on it, you will see a patient health questionnaire, a PHQ-9 form. Typically, the way this is accomplished is asking the patient or having them fill out each of these answers from a 0 to 3. Let's look at the questionnaire now. Number 1 reads as followed. Little interest or pleasure in doing things. The patient would answer 0 for not at all, 1 for several days, 2 for more than half the days, or 3 nearly every day. Number 2, feeling down, depressed, or hopeless. Number 3, trouble falling asleep, staying asleep, or sleeping too much. Number 4, feeling tired or having little energy. Number 5, having a poor appetite or overeating. Number 6, feeling bad about yourself, or that you are a failure, or that you have let yourself or your family down. Number 7, trouble concentrating on things such as reading the newspaper or watching television. Number 8, moving or speaking slowly that other people could have noticed. Number 9, thoughts that you would be better off dead or of hurting yourself. Pay particular attention to number 9, as that can indicate that the patient is having suicidal ideation, which would necessitate an immediate referral to a psychiatric facility or a psychiatrist at the very least. Number 10, if you checked off any problems, how difficult have these problems made it for you to do your work, take care of things at home, or get along with other people? Not difficult at all, somewhat difficult, very difficult, or extremely difficult. So how do you make the initial diagnosis? If you will look again to the right of the screen, you will see the questionnaire explanation, or how to translate the numbers you have obtained into workable, usable information. You will see that the patient completes PHQ-9 Quick Depression Assessment, and if there are at least 4 check marks in the shaded section, including questions number 1 and 2, you must consider a depressive disorder. Add a score to determine the severity. Consider major depressive disorder if there are at least 5 check marks in the shaded section. Consider other depressive disorders if there are at least 2 to 4 check marks in the shaded section. Please note, since the questionnaire relies on patient self-report, all responses should be verified by the clinician, and a definitive diagnosis is made on clinical grounds, taking into account how well the patient understood the questionnaire, as well as other relative information from the patient. Diagnosis of major depressive disorder also require impairment of social, occupational, or other important areas of functioning, and ruling out normative bereavement, a history of manic episodes such as bipolar, or other physical disorders, medication, or other drug as the biological cause of the depressive symptoms. To monitor the severity of over time for newly diagnosed patients or patients in current treatment for depression, the steps are listed out in numbers 1 through 5. I will make note here that once you have established a diagnosis or a belief that a depressive disorder is going on, you then can move on to a secondary screening tool that we will discuss in just a moment. Even if this screening tool were not used, the PHQ-9 is enough to refer to a referring provider. If, however, you want to glean more information so that you can have something concrete to send to the person you are referring this patient to, I recommend the following assessment. For more specified and sensitive screening, one can use the publicly available PROMIS, P-R-O-M-I-S, screening tool to screen for depression. I would think this would be a good tool to utilize once the PHQ-9 has indicated that the patient has indeed or is indeed in a depressive state. The PROMIS is a stronger tool that can allow you to glean more information and puts the patient on a long spectrum. It would allow you to be able to give something to the provider you are referring the patient to, and allows them to understand where they are on the spectrum of a major depressive disorder. When using this tool for adult depression, a raw score is obtained and is then converted to a T-score, which weighs the raw score against a sample population mean and a standard deviation of 10. For interpretation of this, see the following graph. So, with a patient that has now screened positive in both screening models, what is the next step? Well, certainly our first move is to assess that the patient is not in a state in which they are suicidal. Establishing that, a patient must be referred to a psychiatrist or clinical psychologist for assessment and treatment. Generally speaking, any patient that scores greater than or equal to 15 on a PHQ-9 is in need of referral. It is acceptable to probe further with the PROMIS system as a means to see where the patient falls on a risk stratification, and you can pass that along to the provider you're referring to, as we previously mentioned. Additionally, any patient that is manifesting suicidal ideation or requires an urgent referral to a psychiatrist or clinical psychologist, as their life could very well be in danger. A patient with post-traumatic stress disorder or medications that are ineffective also warrant a psych referral. Their level of immediate risk and need will have to be evaluated by you in the clinic at that time. A final thought to be aware of is that no algorithm is perfect in predicting a patient that is in a major depressive crisis. Part of what makes our treatment theory different is our adherence to the holistic model. What we can do with that is use our intuition with the patient, our experience, if you will, to ascertain if a patient is in greater emotional crisis than we would otherwise like to be aware. That is something that sets the holistic model apart from the allopathic model. We have the ability to see and treat the patient as a whole and see how it is affecting their life. That is something that has made nursing the most trusted profession. We should live up to those standards. I think it's clear that given the strong link in patient depression with chronic pain conditions, it is imperative that a chronic pain patient is assessed regularly for depressive symptoms or disorder. If your patient has a less than favorable outcome to a treatment regimen, it may very well mean that a depressive episode has manifested. It will be up to you to make sure that patient receives the treatment they need in that moment and as quickly as possible. It will also bear heavily on your success in treating the chronic pain patient. If you can successfully treat their depression, or at least successfully get them to somebody who can, you can work in tandem with that practitioner and treat their chronic pain effectively. Thank you.